السلام عليكم. كنا نبلش محاضرة يمكن أول مرة بنعطيها محاضرة pediatric cardiology بالبيزك sciences، بس يعني you will get to know إنه pediatric cardiology is most of it is actually basic sciences and physiology. So it's my pleasure. نبدأ بالمحاضرة. So pediatric cardiac disease are largely congenital. Congenital يعني it developed before birth and it manifested after birth. فهي يعني congenital cardiac defects. Many of them are genetics based and others are developmental, meaning it happened later during development of the fetus, but it manifested later. Some acquired heart disease in pediatric cardiology are there, بس يعني هي minority of diseases. We'll talk about 4 cases of heart disease in children, and we will focus on the embryologic origin of this and also how to link the physiology, the hemodynamics to the clinical picture and how the baby or the child will present. So case number 1, we get this child, 2-month-old, in the clinic. And the mother is complaining that he has rapid breathing, that his breathing is faster than usual, and he has difficulty of feeding. He doesn't finish his bottle, and he's not gaining weight appropriately in the past month. When we examine the child, I know you will take the physical examination later, but I'll just highlight a few points with physical examination. We find that this infant has respiratory distress, meaning that he has some difficulty when he takes a breath, and that manifests as respiratory distress signs. So it's clear that this child is breathing hard, or he's trying to breathe with difficulty. He has rapid heart rate, which is tachycardia. He has weak pulses, and he has signs of skin hypoperfusion. So his skin looks a little bit cold. Maybe it's a little bit pale. It indicates that the perfusion to the skin is not normal. And he also has a systolic heart murmur, which is a sound that we hear when we listen to the heart. So an abnormal sound indicates that there is a high velocity blood going somewhere in his heart. And a chest X-ray was done, and it showed an enlarged heart, we call it cardiomegaly, and also congested lungs, which means that the lungs are receiving more fluid than normal or more blood than normal. So it looked a little bit congested. So this is a few pictures of children that might present this way. We mean with the retractions or the difficulty of breathing, you will see that the intercostal muscles are tugged in when he takes a breath. So the negative pressure in the chest is less than normal. It's negative, more negative. So there is retractions. And also the skin might be either pale or might be mottled. We call this mottling of the skin, which is there is like a net on the skin that might indicate decreased perfusion to the skin. And this is a chest X-ray of this infant or similar infant that shows that the heart shadow is large and also the lungs are congested. We mean by congested, as we said, more fluid in the lungs. The lungs should appear black because they're full of air. The air is black on X-ray. So the lungs should look like this color, but there is a lot of white in the lungs. So it means that the lungs are congested. So oftentimes we get a diagnosis of ventricular septal defect in this presentation. There are other probable diagnoses in this child, but the most common one is ventricular septal defect. So what is that? So the embryologic origin of this VSD is a problem with the septation of the primitive ventricle. You remember from the embryology that you have a cardiac tube, you have a ventricle portion of the cardiac tube that has to septate into 2 ventricles. So during that septation, you will get the interventricular foramen. There is a primary and secondary, as you have studied. and the ventricular septum has to be completed. One part is muscular part, and the other two parts are the Cushing's and the membranous part. All have to agree and meet together to form a full ventricular septum. So if a defect happens, then you will get a defect between the ventricles. And that defect can be either in the muscular part, or in the perimembranous part, or in the canal, or in the Cushing's part. Okay. So this is a quick revision. So this is the ventricle after it started looping. You will get the muscular septum starting to grow, and you have the Cushing's, and you have the membranous septum. All have to meet in the middle and cause intact ventricular septum. So when you have a deficiency of this process, you will get a ventricular septal defect. This is a diagram of the heart. So you'll have 4 chambers: left atrium, right atrium, left and right ventricles, and a defect between the ventricles. This defect can be down here in the muscular septum or up there in the perimembranous septum. So the location of the ventricular septal defect is not very important when we talk about physiology. It's important when we talk about anatomy and repair and surgical treatment, which we will not talk about it. So to understand what's the effect of this defect on the heart and how does this defect cause all the symptoms and signs that we mentioned, so we have to understand the hemodynamics. And you know the hemodynamics from the cardiovascular system, that you have a systemic circulation, you have a pulmonary circulation, and they are connected at the heart, but they don't mix with each other. Okay? So this child has a cardiac output, and for congenital heart disease understanding, let's just assume that this cardiac output of this child is one cardiac output, meaning it meets his demand. So there is one cardiac output that goes to the systemic circulation, and follow that cardiac output and see what happens when you have a defect. So this cardiac output that goes to the aorta, it will go to the organs of the body, and then it'll come back through the caval veins, superior and inferior caval veins, into the right atrium. And then from there to the right ventricle. Now we have a problem because we have a defect. So there is a possibility of this defect allowing blood from right ventricle to the left or left ventricle to the right, because there is a defect between the two chambers. What governs the flow is pressure and resistance. So if the pressure in the right side is more than the left, then the flow will go from right to left. But we know that the left ventricular pressure is higher than the right ventricular pressure, right? So we'd expect that the blood will flow from left to right. And also the vascular resistance in the pulmonary artery is much less than the vascular resistance in the systemic artery. So that will allow the blood to go to the lungs much easier than to go to the aorta. So in other words, it's easier for the blood in the left ventricle to cross the VSD to the right than from the right to the left. So let's assume that this defect is really large and it's allowing a lot of blood to cross from left side to right side. We don't know how much. Let's assume how much. So an assumption is 2. So let's assume that there are 2 other cardiac outputs crossing from the left ventricle to the right ventricle during systolic phase of the ventricular contraction. So during systole, you will have 3 going to the lungs, 1 from the right side and 2 from the left side. So you'll get 3 blood components or cardiac outputs to the lungs, and all of this will come back to the left atrium, and then from there to the left ventricle in diastole. So they will fill the left ventricle with a lot of blood, and then when the ventricle has systolic phase, you will get 1 to the cardiac output, which is the normal cardiac output, and 2 will cross again to the lungs. So you will have a lot of recirculation of red blood to the lungs. So it's already saturated blood, but it's going back to the lungs. So it's only causing problems to the lungs, and it's not benefiting the baby. So that can happen in patients with large ventricular septal defects. So what are those causing? What are the problems caused by this? You have a lot of blood going to the lungs, and it's going to the lungs with high pressure because the left ventricle high pressure is pumping into the lungs. So that will result in increased pulmonary blood flow, and that will result in stiff lungs, heavy lungs, because they are full of blood. So the baby will have difficulty of breathing. So that's why those babies will have tachypnea and difficulty of breathing. You will have a lot of blood coming back to the left side of the heart, which is the left atrium and left ventricle. That will result in dilatation of those chambers. And that will give you the cardiomegaly that we see on the X-ray. And you can also elicit that on physical examination of the heart. You will see that the heart is really shifted. The apical impulse is shifted to the left. And you will have a lot of blood going from the left side to the right side through this defect in systolic phase during ventricular contraction. So you will get the heart murmur, which is a systolic murmur, systolic sound that you can hear by the stethoscope. And this child is not only going to be static like this. With further dilatation of the left ventricle, what happens to the function of the left ventricle, the systolic contractility of the ventricles? You know that by the Frank-Starling law. I think you studied this, right? The more you stretch the muscle, initially you will get better contractility, but if you stretch the muscle too much, you will lose that contractility. We call this Frank-Starling law. So if you keep filling this ventricle, so if you're functioning here, that's good, the contractility is good, so the stroke volume is good. But if you keep dilating and dilating and dilating, you lose the interaction between actin and myosin, and you start losing the contractility. So this child, if we don't do something about his condition, eventually he will have decompensated heart failure. He will not be able to continue with normal cardiac function. Any question about this? Okay. Now let's talk about a different case, case number 2. This one is a 2-year-old child who presents with cyanosis. He's blue. He has low oxygen saturation in his blood. And the mother noted that for the past few months, he's been doing squatting movement often. Particularly when he gets more cyanosed, he will squat a little bit for a few minutes and then he will continue playing. Generally, he's been growing well in the first year of life, so he didn't have the symptoms of the other child. He didn't have the heart failure symptoms. He didn't have the tachypnea and difficulty of feeding and difficulty of weight gain. So you look at the child, he's really cyanotic, he's blue, his lips are blue, and he often squats. Okay, every now and then he will do the squatting movement and then he will continue with what he was doing. When we examine the child, his oxygen saturation when he's resting is 80%. The normal is above 95%. He has plethoric face, so his face is really congested with blood. It looks like he's not anemic, he's not pale. On the other hand, he's like purple in color. He has good pulse and good perfusion, so no problem with the cardiac output to the organs. And he has a systolic murmur as well. And because he's now 2 years old, he developed clubbing of fingernails. That's another added sign that we can see in patients with chronic cyanosis. Clubbing means you lose the angle between the the nail and the nail bed. So when we put the fingers together like this, there is no space between them. The X-ray showed that the heart is not enlarged, but it has a peculiar shape. We call it boot-shaped heart. So this is the X-ray. You see the lungs are black. They are actually more black than normal. And the heart is not that enlarged, but it has a different shape than normal. They call it boot-shaped heart, like it's similar to a boot. His hemoglobin was 17. So his hemoglobin is higher than normal for a 2-year-old. So the diagnosis in this patient, so it can be a number of things, but the most likely diagnosis with this scenario is Tetralogy of Fallot. Okay. So what's the problem with Tetralogy of Fallot? So there is only a single problem in Tetralogy of Fallot, which is deviation of the conal septum during development. You remember when we talked about ventricular septum, there is the muscular septum, and there's the Cushing's, and there is the outlet septum or conal septum. They have to meet so that you get an intact ventricular septum. So if this conal septum did not meet them and it deviated to the right side and anteriorly, it will cause the 4 things that we see in Tetralogy of Fallot. So what is the conal septum? It's actually this piece of muscle that you see here. Instead of growing this way to meet the ventricular septum, it actually grew this way to the right side. So by this, it did not meet the septum, so it created the ventricular septal defect. And also, it created crowdedness under the pulmonary valve, so that you'll get outflow tract obstruction and pulmonary stenosis. And it actually pulled the aorta over to the right side. So the aorta now becomes overriding the ventricular septum. So this is the left ventricle and right ventricle, and the aorta appears as if it's coming off both ventricles. The pulmonary artery is smaller than the aorta, and there is this large ventricular septal defect. Secondarily, you will get ventricular hypertrophy because now both ventricles are pumping with the same pressure, so the right ventricular muscle will become hypertrophic. So how does that result in the symptoms that we mentioned? He's a cyanotic child, but he's growing well. He's not having any tachypnea or dyspnea, and he squats often. So let's talk about the same hemodynamics, the same physiology that we will discuss. So cardiac output in this child, this is a Tetralogy of Fallot diagram. So the cardiac output is what goes to the aorta is, let's assume it's 1. It equals to the demand. So 1 cardiac output to the aorta, that will go to the systemic circulation, supply the organs, and come back through the caval veins into the right atrium as 1 cardiac output. And then we'll cross to the right ventricle. Here we have the same thing, which is a ventricular septal defect. So why not this patient have the same symptoms as the other one? Because there's a difference, which is the pulmonary stenosis. So if the right ventricle tries to pump this 1 cardiac output into the lungs, it cannot, because there is fixed obstruction or dynamic obstruction of the outflow tract. So there will be no left to right shunt because it's easier now for the blood actually to cross right to left than left to right. So let's assume that we have only half that makes it to the lungs. So the other half has to cross the VSD to the aorta. Let's continue with the half that goes to the lungs. It will come back to the left atrium, fully saturated, that's why it's red, and then to the left ventricle, and then both this half and the other blue half will go to the aorta. So you'll get an equilibrium with normal cardiac output, but this cardiac output is not red. It's mixed between red and blue. So let's see what happens with the symptoms. So the lungs are receiving half the normal amount of blood. So they're happy, they're not congested, and they can do their work, right? So the child will not be dyspneic or tachypneic, okay? So there is no congestion, no respiratory distress, and the X-ray shows dark lungs, not white lungs. So the obstruction that we have has led to a murmur because there is turbulence of flow across this obstruction. So you will get an abnormal heart sound, which is a heart murmur. This heart murmur is because of the pulmonary stenosis. The VSD heart murmur is because of the flow across the VSD itself. But they both have systolic murmurs. The shunting that we discussed, blue blood going to the systemic circulation, will result in the cyanosis that we have. So the baby will become bluer. His saturation is 80%, not 100%. Okay. So why does the patient squat? So when this child tries to play and try to consume more oxygen, what happens to his physiology that we discussed? So let's say this child, with this scenario, his saturation is 80% because this one is 100% and this one is 60%. You have equal amounts. So you mix red and blue, you will get purple right in the middle, which is 80%. That's at baseline. So if he tries to exercise, if he tries to run around, or if he's crying, he's consuming more oxygen. So this 80% that goes will not come back as 60, because he's taking more oxygen out of this amount, right? So it will come back as 50 or 40. So now you're mixing 40 with 100, you will not get 80. You will get less. So every time this child tries to work harder or run or have an infection, for example, his metabolic demand is higher, his oxygen saturation will drop. So if he's doing that, he feels that he's not right, he feels that he's really getting bluer, so he squats. So when he squats, it means he's stopping the exercise that he's doing, and when he squats, he's compressing large arteries in the lower limbs. Femoral arteries and external iliac arteries are compressed by the squatting movement. So how does that help him? Well, he's increasing the resistance in the aorta. The total resistance in the aorta is now higher, so he is preventing some of the shunt to cross from right to left. So squatting, one thing that squatting does is it increases resistance in the systemic circulation, so it works against the shunt. So it's like forcing the blood to go to the lungs, get oxygen, comes back as red, so his oxygen saturation will improve. Of course, there are other things squatting does for the child which are favorable, helping him to improve his saturation. So now we explained the symptoms based on the basic physiology. Any questions? Okay. So let's talk about a third interesting case. So this child is a 1-day-old. So he was just born, and he was noted to have significant cyanosis just a few hours after birth. And this cyanosis is not associated with respiratory illness. So he's not having a pneumonia or a respiratory distress syndrome or something that might cause cyanosis. So he looks healthy, except that he's becoming bluer by the hour. The saturation was measured to be 70%. So it's even worse than the tetralogy case that we discussed, but he has good pulse and good perfusion. He has no murmurs in the heart. He looks like a very beautiful, normal baby, except that he's blue, and his saturation is 70%. His heart rate is normal. He's not in heart failure. And the X-ray showed also an abnormal shape of the heart. The size of the heart was not bad. It was normal, but the shape of the heart was slightly abnormal. So if we resemble this shape to something, because it's like an egg-shaped heart, smooth surfaces, egg-shaped heart, and the mediastinum, which I know you haven't taken the respiratory system, but this is the mediastinum. It's narrow. It should be a little wider than this, because there is aorta and pulmonary artery side by side, so the mediastinum is wider than this. Okay. Now this baby has a narrow mediastinum. It means that those are not side by side anymore. They are like anterior and posterior. So there is a problem with the great arteries in this patient. Cyanosis is getting worse by the hour. So in 2 hours, now the saturation is 65 and it's really dropping. So the most common diagnosis in this scenario is transposition of great arteries. And you have also studied this, right? So what does transposition mean? It means that the aorta is arising from the right ventricle and the pulmonary artery is arising from the left ventricle. So how does that develop in the embryology or during cardiac development? The problem is the septation of the truncus arteriosus. Again, you go back to the cardiac tube, you have sinus venosus, atrium, and Cushing's, and then ventricle, then bulbus, and then truncus. And most of these have to septate to create the two circulation. The truncal septation creates the aorta and the pulmonary artery, and it has to be in a spiral way. So this is the truncus, so bulbus and truncus, and those have to septate in a way that is spiral. Okay, so that will push the aorta to be posterior and the pulmonary to be anterior. Okay. If the septation happens without spiral movement of septation, you will get two parallel vessels and the aorta remains anterior, which is arising from the right ventricle, and the pulmonary remains posterior, arising from the left ventricle. So you will end up with transposition of great arteries. So this is transposition of great arteries. So the left ventricle gives rise to the pulmonary artery, and the right ventricle gives rise to the aorta. So how does that do to the baby? What does that do to the baby? So the baby is born and he has this arrangement. So let's discuss the same process of cardiac output and see the flow. Where does it go? So the flow, if this baby is alive, we mean that there is some cardiac output, and let's assume it's one cardiac output equals to the demand of the baby. So one cardiac output going to the systemic circulation comes back to the right atrium, same as the other babies. And this will go to the right ventricle, but then all of it will go to the aorta again. So the blood is recirculating within the same circulation. So if the saturation is 80% now, After the first run, it will be 70 or 60, and then 40, and then the baby will have no oxygen in his systemic circulation, right? What about the pulmonary circulation? Also, there is blood in the pulmonary circulation, and we can assume it as 1 or 2 or whatever, and it will also recirculate within the same circulation. So you have 2 separate circulations. They are parallel circulation. So how long does a baby with this arrangement live? Maybe a few minutes or an hour or so, not more than this, right? Because he will have no oxygen in his blood. So that will explain to you that those babies have severe cyanosis, not like the Tetralogy of Fallot. They can have mild cyanosis and then it develops later, and they can live for several years and then get repaired for several months. So how is this baby surviving? Because you remember that in development, you have 2 communications, or actually 3. One is called patent foramen ovale. This is in the fetal circulation. You don't have an intact atrial septum. So this patent foramen ovale will allow mixing of some of this red to the right atrium and some of this blue to the left atrium. So that will help the baby to mix some of the blood. So that's how he survived for a day or for a few days, because he has some mixing at the atrial septum. That's why there is something called emergency atrial septectomy or emergency septostomy. So if the atrial septum has a small defect, not a significant defect, we can actually open this by tearing the septum by a balloon or even by surgical intervention. So we can tear the septum to allow more mixing of the blood if the atrial septum starts to close, because we know the patent foramen ovale closes after birth. You can also help the child by adding another level of mixing, which is present also in all fetuses. After birth, they close within a day or 2, called ductus arteriosus. So if this baby has a ductus arteriosus also, it will allow some blue blood to cross from the aorta to the pulmonary artery. So you'll have now more blood to the lungs, more red to the left atrium, and more red crossing to the right atrium. So another life-saving intervention that we can do for the baby is to keep the ductus arteriosus open, and we know that we can keep it open by giving a medicine called prostaglandin. Prostaglandins dilate the ductus, results in more pulmonary blood flow in this baby, and he has a better chance of survival, awaiting his surgical switch operation to switch the aorta and the pulmonary artery. Any questions? Yeah.
If we open the ligamentum venosum, isn't the pressure in the pulmonary artery more than the aorta?
Yeah.
The blood will flow from the pulmonary artery to the aorta?
So that's a good question. If you open the ductus arteriosus, you mean? So if you have a communication between the aorta and the pulmonary artery in this child, why wouldn't the blood cross from the pulmonary to the aorta? And the reason for this question is because the pulmonary is coming from the left ventricle, so the left ventricle is higher pressure. But that's actually not true. The left ventricular pressure brings its pressure from the systemic circulation. So it's actually my systemic circulation that determines my left ventricular pressure, not the other way around. So the aorta, even though if it's coming from the right ventricle, it has a systemic resistance. So the right ventricular pressure in this patient is actually higher than his left ventricular pressure, because the left ventricle is facing the lungs. The lungs have less resistance, so why pump at a high pressure? So it pumps at a lower pressure. So always when you have a connection between the systemic and the pulmonary circulation, you will get the flow from the higher resistance to the lower resistance, regardless of where they come from right or left ventricles. So the last case is another one who's an older child, a 10-year-old child, who complains of headache, and he has occasional chest pain when he exercises. And he also reports some cramps in his legs when he walks for a long distance, in the calf muscles. A school nurse examined him because he was complaining, and she found that his blood pressure is 160/100. So that's a high pressure for a child. Okay, the normal pressure is 110/70 or so. So he comes in and we further examined the child and we found that he has very good pulses in his radial and his brachial pulses, but the femoral pulses are difficult to palpate. The poor femoral pulses, or what we call radiofemoral delay. Okay. The blood pressure in the legs was also measured and it was 110/70. So the pressure in the arms were 160 and in the legs it was 110. So there is a gradient between the upper and lower limbs. Cardiac palpation showed a very strong apical impulse, meaning that the left ventricle is actually pushing your hand. We call it ventricular heave, and that is consistent with the high pressure. So the left ventricle has to become hypertrophic and it will pump with more force than normal. You took ECG. ECG, we can evaluate the ECG and find out the ventricular hypertrophy criteria. So the forces of the left ventricle on the ECG was high. We call this left ventricular hypertrophy. His X-ray showed notched ribs, something different from what we're not talking about the heart. The heart maybe looks normal or maybe slightly enlarged, but the ribs are notched. So why does that happen in this patient? And we'll show you how the ribs. So this is his X-ray. So the heart, a little bit generous, especially in the left side. If you look at the ribs, they have to be smooth. The undersurface of the rib has some notching, some irregularities, as if it was like eaten by something. So there is some attrition of the ribs. This is a very subtle sign. If you don't look hard, you cannot really see it. So the radiologist has to be very vigilant to see those notched ribs. And he has to ask, what's wrong with this patient? Why did we get the X-ray for this patient? If we tell him that there is a blood pressure of 160 in his arms and the blood pressure in his legs are much less, then he will start looking for something like this. So this patient has coarctation of aorta. There's a disease called coarctation of aorta, which means obstruction in the aortic arch. That's a CT scan of this patient this is the aortic arch, and you can see that there is severe obstruction in the aortic arch. And this is a 3-dimensional reconstruction. You can see that the aortic arch is obstructed right there. There's a lot of blood vessels that are larger than what we see. Those are internal mammary blood vessels that come from the subclavian arteries. Those are some of the intercostal vessels that are larger than normal. So why do those happen as well? So the disease is called coarctation of aorta. What's the embryologic origin of this? It's actually unlike the other ones, which develop during early development of the heart. The heart, as an organ, develops in the first or second or third trimester? First trimester. Most organs are completed by the first trimester, so in the first 12 weeks of gestation. So the organ, you'll have it the same as you see it in the neonate. But some diseases actually happened later, just like the coarctation of aorta. This is the fetal heart. The fetal heart works as one unit, although there are 4 chambers, 4 valves, and all the structures that you see in the normal heart, but it works as one unit. Why? Because the lungs are not used in the fetus. They're full of fluid. You don't need any blood going to the lungs. So in order for that to happen, you need the ductus arteriosus to divert blood from the lung. So the right ventricle is pumping through the ductus to the systemic circulation, to the aorta. And the left atrium does not fill anything because there is nothing coming from the lungs. So we have a patent foramen ovale to allow the blood from the inferior vena cava to cross to the left atrium. Okay. And then the left ventricle will pump the blood to the head and brain of the baby and the upper limbs. شو صار؟ بطفي هيك مرات. Okay, so both ventricles eventually they pump the blood to the systemic circulation. The left ventricle predominantly takes care of the upper limbs and brain, and the right ventricle will pump most of the blood to the descending aorta, and that blood, part of it, will go to the placenta through the umbilical arteries. So when you have any problem with filling of the left atrium and left ventricle, you might get decreased amount of blood going to the upper part of the body, and that will result in minimum blood that crosses the isthmus or the distal arch. So it's a developmental problem. You will get narrowing of the distal arch because there isn't enough blood to cross that area. So that's the most vulnerable area in the aortic arch. Okay. So you will get the narrowing right at this area, distal to the left subclavian, if you have compromised blood supply to the left ventricle. So what happens when you have this narrowing? So just like a pipe and you ligated the pipe, the pressure proximal will be higher, the pressure distal will become less, and the left ventricle has to pump with higher force. So that's when you get left ventricular hypertrophy. Okay. Oh. Okay. So let's talk now what happens of physiology of coarctation, not TGA, sorry. So there's narrowing here. So that will result in higher pressure proximal and lower pressure distal, and that explains why this child has upper extremity hypertension and lower extremity normal or low pressure. Okay? So it's one cause of hypertension, secondary cause of hypertension. One of them is coarctation of aorta. So if you measure the radial pressure, it will be much higher than the femoral pressure. Left ventricle becomes hypertrophic, and if the left ventricle becomes hypertrophic, then it needs more blood supply to function. Right? We call it increased myocardial oxygen demand. So if that happens due to any reason causing left ventricular hypertension is actually a risk factor for angina during exercise. Because when you exercise, you need more blood to the ventricular muscle itself. So if there isn't enough blood, you will get ischemic chest pain. Okay? So that explains why this child has ischemic chest pain when he tries to exercise. So what about the notched ribs? So the notched ribs happen because of what we call collateral circulation. So this is the aortic arch, and this is the obstruction. So limited amount of blood going through this obstruction to the lower extremity. All these other vessels that you see, you have intercostal muscles coming from the arch supplying the intercostal spaces, and you have the internal mammary artery anteriorly. You have even the gastric arteries, etc., epigastric arteries. Those connect to each other to bypass this obstruction. So you get the flow from the subclavian to the internal mammary and then to this intercostal backwards to fill the descending aorta. So you will get what we call collaterals, and that will result in notching the ribs because they become large vessels causing notched ribs. So we explained why this child had the notching of the ribs. It's because of the collateral circulation. Lower limb blood supply may get compromised during exercise. That's why this patient will complain of the cramps in the legs, what we call claudication. Okay. And that's it. أي سؤال عن كيس 4؟ أوكي خلص.
شكرا دكتور، يعطيك
أهلا.
العافية. محاضرة very informative, very interesting. بدنا منك بس 5 دقائق قبل ما تروح على العيادة تحكي لنا عن your path بتخصص البيدياتريك كارديولوجي لو سمحت.
Okay. So pediatric cardiology. So the path to pediatric cardiology starts بعد ما تخلص. ممكن هيك بس استعين بكم سلايد. So طبعا انتم لسه ما درستوا كل الكلينيكال سبيشالتيز، بس يعني clinical specialties are a lot of specialties that you will study وراح تمروا عليها تقريبا معظمها. فينا البيدياتريك ميديسن وفينا الانترنال ميديسن which they both similar in terms of the science that you're studying really the medicine. the true medicine, which is either pediatrics or internal medicine. You'll have the surgical aspect اللي هو surgery والsubspecialties of surgery. عندك الobstetrics, عندك طبعا basic sciences, عندك special surgeries زي orthopedics, neurosurgery, etc. So you will, once you see all of them, be open-minded. يعني إنه يعني ما تحكي من هلا أنا ما بدي إلا هيك أو ما بدي إلا هيك. Just try to identify what's your area of interest, what are the set of skills اللي عندك عشان تقدر تحكي أنا بدي أكون internist ولا بدي أكون surgeon for example. هلا بالبيدياتريك ميديسن once you decide إني أنا بدي pediatrics لأني أنا عندي passion al pediatric medicine, I have set of skills to deal with children, I have set of skills to deal with the caregivers والparents etc. and you have the opportunity إنك تتخصص بالpediatrics. That's all يعني will come together. Then you started with the pediatric medicine. That's 3 years or 4 years حسب البليس اللي أنت بتتخصص فيه. And then in pediatrics itself, just like as in internal medicine, there's so many subspecialties in pediatrics. Actually, more than 15 subspecialties in pediatrics. في common ones زي مثلا cardiology, gastroenterology, respiratory medicine, endocrine, neurology, etc. وفي some others that are closer to the basic science زي metabolic مثلا زي genetics, etc. Emergency medicine in pediatrics, etc. So if you select the cardiology, it has to be also an informed decision based on your set of skills and your interest. شو الset of skills اللي لازم تكون موجودة عندك عشان البيدياتريك cardiology؟ Back to the basics. شفتوا كيف البيدياتريك cardiology really depends على الفيزيولوجي, على الهيمودynamics, clear understanding of those parts of your medical study. So if you think that you really like the basic science, you really like the physics, you really like the physiology, then pediatric cardiology might be something that you can excel in. Set of skills that you might have, the three-dimensional imagination of the cardiac structures, the cardiac pathology, لأنه each child is different from the next. مش نفس الاناتومي اللي بتشوفها بكل الديزيزز هذول. So لازم يكون عندك شوية three-dimensional imagination اللي تفهم الimaging studies, advanced imaging إلى آخره. So that's cardiology. هلا even cardiology has a lot of subspecialty in cardiology. So cardiology, you make like 3 years of cardiology and then you can decide I'm going to be a general cardiologist ولا بدي أعمل إشي subspecialty. في imaging only subspecialty بالpediatric cardiology. So you will study the advanced imaging, cardiac magnetic imaging, CT scan imaging, three-dimensional echo imaging, etc. So that's a separate study. ما فيها interventions. Okay? ممكن في interventional pediatric cardiology to deal with the structural heart disease and how you can treat the structural heart disease or palliate them. فعنا electrophysiology, which is arrhythmias and arrhythmia treatment and ablation therapy for the arrhythmias, etc. في pediatric cardiac intensive care, في heart failure specialty only in pediatrics, transplant in pediatrics. وطبعا في genetics اللي هي بتكون مع كل ال other subspecialties. هذه كمان it's further training يعني 1 or 2 years of training عشان to master those. And the rest of your career will be just more training and more experience with those specialties. ما بعرف إذا حدا عنده أي سؤال if I answered your. تفضل.
شو الفرق بين pediatric cardiology والcardiologist العادي؟
Okay. So now you knew some pediatric cardiology, you will know now cardiology. الفروقات كبيرة بين البيدياتريك cardiology that I mentioned in the beginning. إنه it's really about congenital heart disease. Most of what we deal with is congenital heart disease. Most of what adult cardiology dealing with is acquired heart disease. Now there is some interaction between the two. لما نحكي عن adults with congenital heart disease, that is separate specialty من pediatric cardiology or من adult cardiology. في structural heart disease, it has common grounds between the two. بس أنا مثلاً تحكي لي هذا المريض عنده coronary artery disease, a child with coronary artery disease, I will just run away بحكي للدكتور حنا تعال شوف لي coronary arteries because it's not really my specialty, right? So it's a different world, يعني two different worlds, some common grounds بس كثير في فروقات. Okay. أي سؤال ثاني؟ Thank you very much. إن شاء الله ما تأخرت عليكم.
نشكرك أستاذ دكتور رياض.
شكرا جزيلا.